I know some folks are still joining, but we only have 90 minutes to cover what should be a very interesting discussion. And so I'll get us started today. Welcome, everyone, to GEDC's first roundtable event in 2024, where we're discussing the pressing issue of the capacity crisis facing healthcare today. First, I'd like to thank our funders, without whose support this work would not be possible. Our gratitude to the West Health Institute and the John A. Hartford Foundation. Thank you so much. I'd also like to extend a welcome and gratitude to our 13 participating member systems. The VA, Dartmouth, Hitchcock, California Systems, Advocate Aurora, Northwell Health, Queens, Cleveland Clinic, Kaiser Permanente, Mayo Clinic, the University Health Network, Yale New Haven Health, Prime Healthcare, Sarasota Memorial, and guest system Wyckoff Heights, who are joining us today. Thank you so much. As our healthcare systems face an influx of patients, the limits in infrastructure, staffing, and resources are becoming evident. How are hospitals coping with these soaring demands, and what are the implications for patient care and outcomes? We have with us a panel of experts from various corners of the healthcare industry to provide a robust understanding of the issues at hand and to explore possible solutions. We'll hear from thought leaders representing the Cleveland Clinic, Massachusetts General, UCLA Medical Center, the American College of Emergency Physicians, and Weill Cornell towards the end, hopefully. Thank you to everyone from the Healthcare System Roundtable team that's here today. And also the Geriatric Emergency Department Collaborative and the Geriatric Emergency Department Accreditation, ACEP's Geriatric Emergency Department Accreditation, are leading the way in helping hospitals and institutions build their GEDs. And we have lots of exciting things in store for our members. And please, hopefully someone can put in the chat our website link. Please join us online and sign up if you are not already a member. Lastly, you, our roundtable audience, will have the opportunity to raise some questions and contribute to the discussion through the chat function in Zoom. And our esteemed colleague, Renee Tiska, will be collating some of your questions for the open roundtable discussion after our panelist presentations. So together, we hope today fosters a dialogue that will not only educate, but spur actionable steps to address the capacity crisis in healthcare. And let's begin by addressing the first point on our agenda, the current state of the capacity crisis and how healthcare institutions are adapting to this escalating challenge. And with that, I will pass the microphone to our colleague and friend, Dr. Steve Meldon.
Connor, thank you very much for that introduction. And I'd like to welcome all of our guests and attendees and thank them for joining. I am Steve Meldon. I am an emergency physician, and I co-direct the Geriatric ED program at the Cleveland Clinic. We are very excited to have everyone here. This is an interesting presentation, something that's very much top of mind for everyone. We will be talking about boarding strategies, overcrowding, and shortages in the geriatric ED. I think we are all aware that ED boarding is now at crisis levels. Significant national attention to this, including articles, news stories, and even now legislation looking at that and regulatory efforts to address. I think it's important to start off by saying that ED boarding is not an issue of poor ED operations. It is an issue and the result of significant inpatient capacity issues. Obviously, these causes are multifactorial, some we'll talk to, but there's post-pandemic demand for healthcare. We still have significant staffing shortages, both on the inpatient side, but also post-acute side. There are significant financial pressures, staffing costs, pharmaceutical supplies, inflationary pressures, and financial incentives to prioritize other things. And this is especially true in the time of decreasing margins for all of our healthcare system. Boarding is really now at an all-time high. The Emergency Department Benchmarking Alliance, an alliance of 1,200 EDs representing 34 million ED visits, has noted that they've never seen lengths of stays, median length of stays, and boarding like we are now seeing. As we know, this has a significant impact on the ED. It has patient flow disruption. There are clear impacts on patient care, which we'll talk about. You can imagine patient satisfaction is not improved. And I'd also like to call out the impact on caregivers. We know that burnout is a significant issue when you are faced with loss of autonomy, loss of control. Clearly, that has an impact on how you feel about going to work. I would also suggest that these kind of conditions can actually increase the chance of workplace violence, which is also very much something that we're concerned about with our caregivers. Now, importantly, these impacts disproportionately impact older patients, which we'll hear about some today. Today, we will focus on the capacity crisis facing healthcare, how to navigate the complexities of overloaded systems and care prioritization, discuss resource management shortages, and really explore innovative boarding and policies to combat overcrowding and staffing. Next. I'd like to introduce our panelists. It's a pleasure to have Lynne McCullough from UCLA, Maura from Massachusetts General, Tony Rosen, Weill Cornell, and Erin Grossman from the American College of Emergency Physicians. Maura, I think we'll start with you.
Great. Thank you so much. So I have been asked to kick off the roundtable by talking about the true costs of boarding, and specifically on our older patients, really to frame this discussion, but hopefully also to help us as we think through the different solutions we may implement to mitigate some of these harms for our older adults. But before I get into that somewhat depressing talk, I did just want to pause and acknowledge what Steve already did, that this is truly a crisis for us locally, a crisis nationally, and a crisis internationally. It has real impacts on our hospitals and our patients and our staff. And I just wanted to put up this from Mass General to sort of reflect on the crisis that we're facing. So in January, we kept hitting personal bests, and not bests that we were proud of. We kept day after day hitting the highest number of patients boarding that we've ever had until we hit on one day in January, 103. That was the largest number of patients we had boarding in our history. It was just devastating for our patients and for us. And we actually put out a press release about the challenges that we were facing in our emergency department with boarding. And I wanted to share this specific quote that I really appreciated from a former chair of our emergency department and now the president of both Mass General and Brigham. And he said that every day between 50 and 80 patients spend the first night of their hospitalization in the emergency department in Mass General. It is not an appropriate or therapeutic environment, and it contributes substantially to clinician burnout and frustration. And so I wanted to frame our crisis as we get into the broader discussion about older adults. Next slide. So there are three main areas I'm going to talk about. One is the unique impacts of boarding on older adults. I'm going to briefly touch on why boarding begets boarding, particularly when it pertains to older adults. And then I'll touch on what Stephen already talked about, which is the fact that this is a workforce issue, not just a patient issue as well. So why would this disproportionately impact older adults? We know boarding's bad. We know that it delays antibiotics. We know it can result in delays to cardiac catheterization. And for those who are critically ill, it can result in longer ICU stays, longer ventilation, higher mortality. Why is it geriatric specific? It's just a bad thing. Well, there's a few different reasons for that. First of all, is that boarding does not happen equally. It's not distributed equally. Older adults are actually more likely to board than younger adults, and older adults are more likely to board for a prolonged period of time than older adults. So they disproportionately have more of the boarding impacts than younger adults. And they're more likely to be harmed in different ways by boarding. So the first thing we think about, and when we sort of go to the penultimate concern about boarding, is its impact on mortality. a number of different studies discussing mortality generally, with some mixed impacts on boarding and mortality. One systematic review suggested that maybe the difference is reflective of older adults in the population. And I think most of us have seen the article that was published in JAMA Internal Medicine by Rosen et al. From France that said, compared to people who spent their first night in an inpatient unit, those patients who boarded in the emergency department overnight were more likely to die. 16% mortality compared to 11% mortality. In adjusted analysis, that was 1.39 for an adjusted risk ratio. And individuals who were more disabled, who needed help with their activities of daily living, had an even higher adjusted risk of death. And so for older adults, that one night in my emergency department may mean the difference between life and death. How is that mediated? What is the cause of that death? It's probably multifactorial. And as someone who always talks about delirium, I will tell you that I think delirium is a part of it. We absolutely know that staying in our emergency departments for a prolonged period of time results in delirium. Longer ED length of stay, 10 to 12 hours, higher rates of inpatient delirium. A great study that shows that ED hallway length of time is associated with delirium. Movement between different care areas in and out of the hallway, in and out of different rooms is associated with delirium. And delirium is deadly. Delirium is associated with higher mortality. Delirium is also associated with longer length of stay, which we'll get into as we get to my second point. There's also emerging data about length of stay in older adults and both physical and chemical restraint use. Certainly, we've known from existing studies that if you present to the emergency department with a behavioral health issue, longer lengths of stay is associated with higher rates of chemical and physical restraints. And part of that might be because, if you have a psychiatric emergency, you may end up in physical restraints or might need chemical restraints, and that results in longer lengths of stay because it's harder to get you to a psychiatric facility until you're no longer in physical restraints. But the reverse might be true. The longer that you're in our emergency department, the more agitated you may become, and the more likely you may to require restraints both physically and chemically. And there's a couple of studies that will be forthcoming in the next few months that show that association between boarding and physical and chemical restraints in older adults. The other one that I wanted to touch on that we don't really talk about very often is the sense of this idea of hospital-acquired disability and the impact of immobility on hospital-acquired disability. And I'll put the link in the chat just after I talk, but Kovinsky had this demonstration in some inpatient studies from a while back that older adults leave the hospital more disabled than when they arrive. About 1/3 of older adults, when they get discharged from the hospital, have a new disability that they didn't have when they were admitted. And when you look at people who are 85 and older, that goes up to 50%. So we cause disability. Some of that disability might be related to delirium or a medical issue. Some of that disability is actually mediated by immobility. And in the inpatient unit, some studies have shown that an older adult on an inpatient unit is in bed for 20 hours a day. Now, if with the staffing that they have on inpatient units and the training that they have on inpatient units, an older adult is in their bed for 20 hours, imagine what that means in the emergency department. Is it 22 hours? Is it 23 hours? Is it 23 and a half hours? I would guess for a lot of our older adults, and particularly for those with physical disabilities, it's probably upwards of 23 to 24 hours of immobility, which in turn means disability, which in turn means longer lengths of stay, which in turn means post-acute care admission, as Dr. Meldon was saying, which in turn means longer length of stay waiting for that facility to be able to accept your patient. And that gets into this concept of boarding begetting boarding. If you develop delirium because you were in an RED for a prolonged period of time, you're going to have a longer length of stay and likely need to go to a post-acute care facility, and then you're going to have an even longer length of stay. And if you develop a hospital-acquired disability from being immobile in our emergency department for a prolonged period of time, you are more likely to end up needing post-acute care and then end up needing and have a longer length of stay, which all of those things then mean the hospital is fuller for longer and our boarding crisis is worse. And so it's that cycle at the bottom of boarding begetting boarding and this capacity straining our ED even more. And there's one other thing that we don't really think about a lot, but I think we should reflect on as well. When we are boarding a lot of patients in the emergency department and the responsibility for those patients falls on the shoulders of emergency physicians, we are actually more likely to admit patients than discharge patients. And you would think it would be the reverse. You'd think we would say, oh goodness, we need to try and not admit this patient because we're at such great capacity. But studies show we're actually more likely to pull the trigger and admit someone. And I suspect that's probably just because we don't have the time to spend to think about, is it safe to provide care in a different venue, to better understand the care that this patient has at home, or their care preferences. We're just pulled in enough directions that we just can't spend the time on that. And then I'm just going to finish it up on sort of that last slide, which was already sort of discussed, which is this is not just an issue around harms to patient. It needs to be the center of our discussion, but we have to think about the impacts of this on our staff. In times of excess capacity, we are not providing the care that we want to provide. And it's not because we don't care, and it's not because we're not good clinicians. It's simply because we're being asked to do more than we physically can. And it's because we don't have the space to provide the care that we consider the best of care. This causes moral injury. This makes us less proud of the care we receive. This makes us more burnt out. And this makes us more likely to leave the practice of emergency medicine. I certainly have seen that in my hospital. We've lost a lot of amazing emergency nurses because of this cycle of burnout. And as Dr. Meldon said, violence actually increases substantially in the ED as capacity increases. That in turn drives more burnout and more attrition for our hospitals. So with that, I am hopeful that we turn a little bit more of a positive note as we get on to other speakers about some of the things they've implemented to mitigate some of the adverse effects to older adults.
Thank you. All right, I'd like to really kind of approach this from a system leadership and strategic planning perspective. You know, as I was reflecting on this, I was talking to one of my administrative colleagues. I said, I've been working on hospital throughput for 10 years. And she said, you're not doing very well. She's right? We've been working on hospital throughput for a long time. Next. But it wasn't really boarding hours that got everyone's attention. This is a scatter plot showing the correlation between boarding and left before treatment complete. And there is a clear, strong correlation. And it was that increase in LBTC from about 4% here at main campus to over 15% that really galvanized people and said, we cannot have these people leaving. We are not serving our community. Next. So really, I think there's a couple ways to look at addressing capacity and boarding issues. The first is really, what can the ED do? What are the ED efforts? Remember, we're going to mitigate boarding. We're going to mitigate the impact of boarding. We're not necessarily going to fix it on the ED side. And on the front end, I think a lot of us are now using physician and triage or physician intake programs. Once again, that does not impact boarding. It does significantly make you more operationally efficient and decrease LBTC, which is what we've seen in our experience. On the back end, I think a lot of us now have admission transition units. I'm hopeful that even getting the patients out of the ED setting into a quieter setting really can mitigate a lot of the things Maura talked about. I think we've done a couple other things on the ED side. We had something that we call the Med Hub program. In the Cleveland Clinic, we also have 12 regional hospitals across Northeast Ohio. And we really wanted to get the right patient to the right hospital. And where there was capacity issues at some of our major hubs and main campus, could we transfer some of those patients to our regional health facilities? Pre-pandemic, we were very successful at this. Here at Maine, it was 175 a month, which is a fair number of transfers for our patients. And it was really a good program. COVID really kind of took the wind out of it. We're reinvigorating this again. There are some components like having an access nurse who really talks to the patient. We'll rearrange everything that really can help it. I think another ED approach is alternative disposition programs, right? The practical alternatives to hospitalizations. Even pre-COVID, we developed an ED to SNF because we had the waivers for the 3-day qualifying admission. That was successful. That can help decrease basically the hospital census. We are now with help from West Health on our Geriatric ED VBCO Learning and Action Network. We're going to see if we can't use Home Care Plus, which is essentially a very intensive rehabilitation program at home and keep people out of the SNF. So once again, avoiding hospitalization. Hospital at home is something that we have really taken off in Florida. I will tell you, they've had about 850 patients placed in the hospital at home, average age 72. So a big proportional impact on older patients. We have very aggressive goals down in Florida of 10% of hospital admissions trying to go to hospital at home. So we are certainly excited about that and hope we can continue that program. The other thing we learned on the ED side is that our Geri ED had a significant impact on potentially avoidable admissions. We use the ED observation unit model where you can now take time to dive into those complex patients. In fact, we coined the term high complexity, low acuity for these patients, right? We have case management, our geriatrician team, and we really drove down significant admissions if you were seen by the geriatric team. And I think it really gets to that, this patient is very complex. I don't have time to really figure this out. Let's just admit them. And we're able to back that out a little bit. We've actually now looked at that 2 years later with just our ACO population and have very similar numbers. So we're excited about that. Next. Now, I think that's the ED side. We've talked about this being really a hospital issue. So what is the hospital doing? Well, we've had significant efforts on our hospital side, and I have to thank all my colleagues, Department of Hospital Medicine and Operations, for really the work they've done. We've had essentially 4 different task force work streams: ED throughput, hospital transfer optimization, discharge delays, and discharge efficiency. And they're really looking at each of these things. The hospital transfers is really trying to right size the transfers in, because we know this is a zero-sum game. We have ED admissions, we have transfers, we have elective admissions. There's only a finite amount of resources. So they're doing a lot of work to bring in the appropriate transfers and try to get other patients from outside our system to our regional hospitals. On the discharge delay side, I think everyone really should dive into this if you haven't. There are significant delays that don't have to occur, and they typically revolve around laboratory testing and other tests like echoes, endoscopies, MRIs. So once again, a lot of work has gone into that, trying to raise that visibility, trying to get support to get those tests done either promptly or get them done in an outpatient setting. But I guarantee you, if you guys dive into this, you will find a lot of patients waiting around for something that probably doesn't impact their disposition at that point. So once again, an important part to look at. Discharge efficiency, I think we all know this. When are patients discharged? They're discharged at 6 o'clock at night, right? The hotel industry would never run the way we run. I will say that. We are looking at really trying to increase the number of discharges by 12 noon. Rather modest number, 18%. All right. 1 in 5, a little less. So we really would like to get the people discharged earlier. We're looking at pickup persons. There's a discharge lounge, which I've mentioned there at the next bullet point, and really looking at how do we get the discharge done earlier? What kind of discharge order utilization and discharge planning needs to happen to make this happen? What about prescription delivery to the bedside? What about helping with patient transport? It is more cost effective for us to pay for a medical Uber, right, than keep somebody in a bed until the next day while we're waiting for their family. So I think there's a lot of opportunities on discharge efficiencies. We have a discharge navigator. There is a 1 phone number to call, and their goal really is to help complete the discharge process. What are the barriers? What can we do to basically mitigate those barriers and get the patients discharged? I mentioned the discharge lounge. The little graph there is simply the utilization and at what time they go. You can see it's basically 2 o'clock, between 2 and 2:30. So we are using that. We're getting those beds free because that is when the ED capacity really starts to hit a problem, right? We get busy starting at 9 o'clock, build. So really look at the music there, where it was So I think it's really looking at your capacity and your ED capacity to help with that. Are there any advice on that?
Is this where we do a group dance?
All right. Then future state, this is interesting. So where does predictive analytics help? We're using Palantir Hospital 360. We're really trying to look into system-wide visibility and patient flow and then project staffing needs. I think, the challenges we've always had is this very, very complex operational environment with a lot of archaic legacy systems. They had very poor visibility. We all know about the NOM in charge of the beds, right? A single person. And we're really, really looking at that. So don't underestimate that challenge of your legacy systems, the complex environment, and really trying to get true, clean operational information. What we're focusing on is capacity management and then staffing matrix. Once again, pulling together archaic, disjointed manual processes and really trying to automate them. I'd say, tech is an enabler. People and processes still matter and are crucial, but the tech really can help us. So think about the benefits of automation, of predictive analysis and AI. And really, I think that is going to add a layer of just visibility and transparency to all of these efforts and really help with this. Next. So briefly, just want to talk about what we are doing in the geriatric ED. Basically, we follow GEDA's two-pronged approach. The first is to try to reduce boarding, and then what can you do to mitigate the impact? So more on that later, but quickly, we have centralized bed management at the Cleveland Clinic. We use our EMR to screen for high-risk patients, and now we've automated that right into the bed request, so that our centralized bed management sees that little penguin, that high-risk geriatric patient, and our ask is for them to really prioritize the bed assignment for that patient. We do have a longstanding boarding policy. We were very magnanimous, and we let people basically start to take control at the 4-hour mark. Many people said it should be at hour 0 or maybe hour 2. But ours was written up at the 4-hour mark, where now the care teams are really responsible for that patient. And I think that's an important point. It actually improves the care, it improves the transitions. And, one thing, we're very good at a lot of things, but we don't do inpatient care in the ED. We don't do that well. It's not how we're designed or set up. Next. So I think the key question is, is this working? Well, this is main campus. This is our lengths of stays for our older patients, high risk and low risk. We put the process with the bed management right at the end of September in October, and it looked like we were driving it down, and then a little bump back up, and now it's going back down. Next. And then looking at system wide. So this is all of our EDs. And once again, it looked like we were making some nice progress there. Just to let you know, there's so many variables that impact boarding. I think it can be difficult to tease out any single process change. But we clearly drove down some times. We had the blip in January, and it looks like the times are going back down. So more to come on that, but I'm hopeful that prioritizing will have some impact. So thank you for your attention. I'm going to turn this over to Lynne.
Well, good morning, everyone. Thank you for having me. I think those were great talks to lead into the concept of where we realized where we are. So I'm going to talk to you about the creation of a GED boarding unit and make a case for cohorting your patients. Not all of us, have the luxury of having a separate geriatric emergency department, or really even having separate areas in your department where you can cohort people. But even if there's a way to just bring a few of the geriatric patients together, we're finding that we're able to optimize care for those patients. And I wish that I had Dr. Meldon's numbers. When I show you my numbers, they're really scary. We are in the process of developing some of those tools with bed prioritization, and we hope that that's going to really have an impact on moving the patients up. But in the meantime, let me tell you a little bit about what our environment of care is like. So we see about 55,000 patients per year in our main campus at Ronald Reagan, and a quarter of our population is greater than 65 years old, and we admit 50% of all of those patients. So pretty high admit rate overall for all patients, 31, 32% for all comers, but even higher for our geriatric patients. We have 41 licensed beds. And in following with Dr. Kennedy's statements, we are also in the 40 to 80 per day. So we're doubling our actual licensed capacity with boarding patients on a regular basis. We have not hit 103, but we regularly hit into the mid and high 80s. And I think this morning we are about 70 patients. So there's really not a lot of space to actually become, to deliver emergency care when greater than 50% of all the time that we have, all of the beds that we have are occupied with boarders. So that's what that graph from Tableau shows you, is the percentage of time that our department has 0 to 29 boarders, the next 10 up to 39 boarders, then 40 to 49, and then greater than 50. And originally we had it like spread out, and it goes out pretty far when you get into the 80s and 70s and 80s as well. So looking at all that and being responsible for our geriatric emergency department, I really struggled with the concept of what my role was. How was I really improving care for geriatric patients in the department? Next slide. And looking at it, I realized that the emergency department care of our geriatric patients was moving further and further towards the front door. We were spending more of our time delivering care out in the waiting room areas. Many of the screenings were taking place in the waiting room areas. And it just didn't feel like we were having the impact on the geriatric population that we could. And of course, with everything that, Dr. Meldon just talked about, we're doing all those things too. We're really trying to fix the problem with boarding. We're trying to do all of those efforts and get the patients out. And yet, as that's occurring, we're realizing that what we're doing isn't working, and it's getting worse, and it's getting every day you have new challenges. And so we're trying to modify and we're trying to adapt. So we started moving a lot of those screenings closer. We developed the concept of like a Q2 nurse out in the waiting room, and we started to move some of the geriatric screenings into that nurse's navigator so that maybe it could trickle up these higher risk patients at the point of discharge for those 50% we can get out. And then as I was looking at it and walking the department and observing, where are my geriatric patients? What kind of an impact am I really having? I realized that the majority of the geriatric patients were past the velvet rope. They were in the department and they were boarding everywhere. They were in every nook and cranny. They were in every hallway, and they weren't together. And when I looked at the nursing care, you would have one nurse caring for a pediatric patient, for a geriatric patient, for a trauma patient. And each of those patients have specialized needs. And of course, my heart is with the geriatrics. So I was like, it just seems like we're not doing everything we can. Many of the places where we were boarding the geriatric patients, we couldn't even put a full-size hospital bed. So how could I possibly, with integrity, say, like, I'm doing the best for geriatric patients in this environment where I'm walking down the halls and I'm seeing they have no call bells, they have no access to food and water. This is supposed to be the bread and butter of what I'm doing as the leader of this geriatric emergency department. And recognizing that and that care gap for the seniors in our department, we started to run some numbers. And this graph that you see at the bottom, hopefully it's clear enough for you to see, but there's 3 different cohorts on there of the time that patients are spending in the emergency department. So well beyond the first night that Dr. Kennedy talked about being in the emergency department, we're talking like upwards of 50 hours. That's more than 2 days of their entire length of stay that they're spending in the department. And despite tremendous pressure on patient placement to get these vulnerable and frail geriatric patients out of the department, it just isn't happening. We'll bend the needle a little bit, but then we had the same pattern that Dr. Meldon showed where, it's typical, right? Flu season, boarding tends to get worse in January, February, and then we start to drift down, we hope. I couldn't even put the adult 18 to 64 on this chart because it's not okay, but it's a lot lower than anyone who's 65, 75, or 85. So if you haven't looked at this data for your own department, I think it's really important. And also to work with your patient placement, if you have it centralized and you have the ability to integrate these items into the algorithm that they use for prioritizing placement, I think that's the best way to go. But even without that, we have to find some way to advocate for these adults because there is more heavy lifting involved with caring for these geriatric patients. And I don't want to admit this, but I think there is some cherry picking that happens. You'll see a bed that gets assigned and then it gets rejected. And when you try and dig into why it was really rejected, it's not clear. And yet they'll pull the younger adults who are less work. And so I think this is an area where, regardless of whether or not you end up cohorting your patients together, this is a way to bubble up a vulnerable and frail population and make sure that you can bend this curve below the curve of those patients who can tolerate the boarding process more than our seniors who are at risk. Next slide. So as I went to Gamba and I'm looking around and I'm seeing everything, we're seeing all the things that we had already kind of touched on. So care in the hallways, it's literally 50 plus hours, 24/7 lighting and noise. Talk about, the impetus to have delirium. I mean, we are literally hurting these patients by having them draped all over the halls in this way. There was many care areas that I already mentioned where we can't have an appropriate full-size bed. Can you imagine being 75 years old and on an emergency department gurney for greater than 50 hours because the boarding area that you were placed in can't accommodate a bed, let alone a bed with one of the really good Isoflex mattresses that we know help to reduce pressure ulcers. There's totally, until maybe 4 months ago when we put these battery operated buttons taped on the wall in hallways, they did not even have the ability except to scream, to ask for help, to get out of the bed, to use the toilet if they were thirsty, if they were hungry, if they had pain, if they were tangled up in their IV. And so you could go down the hall and see some of those patients with their legs coming through the gurney. We've all seen it, or trying to climb over, or trying to scoot off the bottom. It was absolutely fall risks right and left everywhere I looked. And we also, and Dr. Kennedy talked about this, if you're in those places where it's even harder to kind of mobilize you, how many hours out of each of those 24 hours are they spending in that bed? Before we started doing this cohorting, they were not getting out of that bed at all, 0. So it was a full 24 hours. And you could see on the slide that I showed previously, where if they're spending 50 plus hours, that is continuously, potentially on an emergency department gurney. So the deconditioning was real and very significant. We couldn't maintain getting them drinks and food. If there's no room for a hospital bed, there's no room for a bedside table. There's no room for a bedside table. So now they're trying to even eat with the food resting on their chest with no one to help them. And so they're not even getting, even when we deliver the food to them, it was inadequate and they had nobody to help them. The volunteers were walking around, but if they stood at the bedside in one of our hallways trying to help a senior eat or drink or bring them things, they felt like they were in the way. And so they were kind of avoiding doing the type of work that they want to do and why we've trained them to be there to help our seniors because there's no space to do it. And then just a little bit about the nursing piece. So in our emergency department, we've gone with a zero sum, Dr. Meldon. We're like, as soon as we say you're admitted and they drop the orders, they are off limits for our emergency department practitioners because that's not what we do, right? We're not good at that. We've also been very successful in transitioning the care to inpatient nurses. The problem is that those inpatient nurses for many, many years were part of the float pool. So they might be on peds one day, they might be an adult, they might be on a surgical unit. And when they were given the inpatients, they were given them with no thoughtfulness. It was just, you were the next up. And so you would maybe have a cohort that was very diverse. And by thinking this through, we realized, could we have a group of nurses that we then train around the vulnerabilities for this population, and they preferentially care for them? So with all of that, we said, can we do this? Next slide. And we have a 10-bed unit. Basically, I gave up my office a decade ago and a lot of the nursing offices in order to turn it into 10 more licensed beds. We used to be 31, now we're at 41. Well, almost as soon as we flipped that switch, we started to have boarders flow in there. Now, during COVID, it was beautiful. They were emergency department beds and they were oftentimes unfilled because we didn't have the volume that we have now. But as soon as the volume started to ramp up again, this 10-bed was no longer emergency department space. They're licensed as such, but it became a place that all the boarders got moved to. And by thinking through and observing all of the things that I've already mentioned, we said, what if we use that unit as the place to cohort all the patients? And we said, if you're over 75, as soon as that switch flips and you are admitted, you're going to be the next one to be pulled into the 10-bed. And so since we made that decision in September, and it's thanks to an incredibly strong leader over what we call our virtual emergency care unit, which is essentially our virtual boarding unit. And we are the largest admitted unit in the entire hospital, much larger than any other floor or any other division. And she said, let's start with greater than 75 and let's start pulling them in there. And the aspects of that area are not just the personnel, but it's also the physical changes that are all there consistently. So the windows can come up and down so they can adjust for light, and they're very sensitive to controlling that for our seniors. Because it's this controlled unit, we are able to put soft closed doors so that as the clinician teams came in and out through the night, it's not a loud door opening and closing because it's 10 patients and they're separated only by curtains and like half walls. We made sure that every bed in there has the type of mattress that a geriatric patient would benefit from most. They're all low height beds. And then we put bed alarms on all of them. Although there is direct visualization from this nursing unit of all of the patients, we do try and like pull the curtains. And so we put bed alarms because when that curtain's closed, we don't want to miss the direct visual. We have a food and drink station right there, and we're able to put bedside tables for all of those patients. So if they are not NPO, and of course we're discouraging NPO designation in this space as much as possible, we have the ability to continuously see that every one of them has good access to food and drink. And then we have a little ancillary area right next to it where we have one of each of the type of mobility aids a geriatric patient might need. So there's no delay. If someone needs to get up, use the restroom, do something immediately, you can go and grab the equipment that you need for this cohorted group of patients. We reconfigured the bathroom so that the minute a geri patient, although they could be helped there maybe with a Sarah study, there's handrails through the entire bathroom. So it's kind of set up for this population to be safer there. And then we have a geri cart that can be rolled throughout this 10-bed unit that has just about everything from denture cups to Sudoku to crossword puzzles to magnifying glasses to hearing amplifiers. We have a blanket warmer. So all the things, and then we trained the nurses in this area to be looking for that. Do they look cold? Do they need another blanket? Do they need stimulation? Do we need a volunteer to sit with them? They have not had family at that bedside the entire time. Are they suffering from loneliness? Are they starting to get a little bit confused? And then they will differentially ask the volunteers, sit, play cards with them, play chess, play checkers, whatever it is that will make that patient allow the time to pass a little bit more. And like I said, we are prioritizing placement in this area for patients greater than 75. And then if we've passed through the whole department and there's no more and we get an open bed, then we'll go down all the way to 65. But nobody below 65 is going in this unit. And it's been continuously full for better and for worse ever since we started in September. Next slide. So really, I think some of the questions that I'd like to hear from you guys is when you think about doing something like this in your own emergency department, what kind of impact should I be looking for? What kind of impact should all of us be looking for? What do we want to measure to know that we've been successful? Because again, the goal is to eliminate this problem. But until that happens, what can we do so that we have integrity in knowing that we're really doing the best that we can for the seniors that actually are in our department for many, many hours in an inappropriate setting? So I put a few things out here for you to think about. Can we compare delirium rates? What will we need to put on that in order to better understand it? How do we measure deconditioning? Dr. Kennedy talked about how that begets boarding because the more time they're spending in the bed. How much mobility do we need to have in order to hit that threshold where we actually are making them mobile enough? Should we look at whether or not this boarding unit is impacting the overall length of stay by DRG? How do we measure patient satisfaction specifically around what it's like to be in this unit that's specially designed for you? And how do we highlight that and make sure they understand that that's what we're doing? Because I would think if even I was in that unit, I'm still very upset that I'm boarding in the emergency department. But how do we create a spin around that so they understand we really are doing something special for them, even though it feels like they're not special at all and they belong upstairs? The staff experience, the morale. We have seen that the nurses that are working in that area have completely embraced additional training, additional education. They're excited to share it. Now they're sharing it with the staff. so that if one of those staff members is on the floor caring for a boarder that hasn't made it to the 10-bed unit, the overall understanding of the needs of patients because of the expertise of the group in that area is starting to leak out and spread. And so it's like a really exciting time to see the focus on this population. I feel like we're kind of reaching that tipping point that, you know, with pediatric emergency medicine happened a long time ago. I really want to feel that cultural shift in my department, and I'm sure you guys want to feel that if it hasn't happened in yours. How do we look at, you know, admission recidivism? If we really are making them mobile, if we're really doing a better job, will this cohort of patients be different, look different on the back end of their hospitalization? And anything else that you think we could do in order to improve the care of the boarding patients, I would love to hear from you. So thank you so much.
Hi, everybody. My name is Erin Grossman. I'm the Regulatory and External Affairs Manager at the American College of Emergency Physicians. I'm going to talk to you guys today a little bit about the governmental landscape of policies around boarding, a little bit more about what ACEP is doing. We hear your concerns about boarding, and we are doing some really exciting initiatives and helping to put things in order to help your EDs. Next slide. So this is just kind of an overview of the legislation that's been introduced in this Congress to alleviate the ED boarding crisis. So a lot of these are not necessarily directly addressing boarding as a ubiquitous thing, but kind of trying to, as we know, it's a multifactorial issue. So trying to get at certain pressure points that contribute to the boarding crisis. So we have the Improving Mental Health Access from the Emergency Department Act, which provides grants to EDs to increase access to follow-up psychiatric care. The Helping Kids Cope Act, which helps fund necessary staffing, capacity increases, and infrastructure adjustments needed to alleviate pediatric boarding. The Mental Health Infrastructure Improvement Act, which establishes a loan program to fund the construction of mental health or SUD treatment facilities that provide inpatient care. And the Providing Access to Treatment and Housing, or the PATH Act, which expands access to mental health and behavioral health services, including SUD treatment. So as you can tell by those bills, a lot of those address the psychiatric boarding problem, which, as we know, is not the only aspect of the boarding problem, but hoping that if we, you know, take care of some of those points, that then we can focus on other aspects of the boarding crisis. Next slide. In terms of the regulatory landscape, so there has in the past kind of been a reluctance by CMS or disinterest by CMS to address the boarding crisis. As I noted here, CMS discontinued the ED2 median admit decision time to ED departure measure in the 2022 IPPS. So it was first established in the 2017 IPPS, the Inpatient Prospective Payment System. They do a 5-year review. In 2022, they decided to sunset the measure in the 2024 performance year. We were adamantly opposed to this. CMS relied very heavily on one meta-analysis that looked at 12 studies that did not find a clear association between ED boarding and in-hospital mortality. We believe that this is false, and we pointed them to a myriad of studies that disproves this. There have been additional studies that have come out since. I think one of the presenters talked about the study in France that made a direct link between boarding and patient mortality. And then because that ED2 measure was sunsetted, a lot of people were using the left without being seen measure in the OPPS, Outpatient Prospective Payment System, as kind of a proxy measure. CMS last year attempted also to remove that measure, and ACEP was successful in convincing them otherwise. So yeah, as you can see, we've been really upset with CMS in terms of their perspective on boarding measures, but I do feel like the tide is kind of starting to turn. There exists the age-friendly hospital measure. This is an updated measure that combines 2 measures previously reviewed by the National Quality Forum Measure Application Partnership, which was the geriatric surgical measure and the geriatric hospital measure. It's now just one hospital measure. It incorporates elements of the Improvement or Institute for Healthcare Improvements Age-Friendly Health Systems Program, known as the 4Ms, GEDC standards developed by ACEP, and the American College of Surgeons Geriatric Surgical Verification Standard. There's a specific piece in that. It's an attestation-based measure that addresses ED boarding. It's domain 3, attestation 6, which hospitals need to attest that protocols exist to reduce the risk of ED delirium by reducing the length of stay, either 8 hours since arrival or 3 hours after at mid-time. And then there's another measure currently being developed for CMS. For the hospital outpatient quality reporting program, we actually were fortunate enough to have one of our doctors sit on the technical expert panel that helped to develop this measure. And its goal is to capture variation of equity in emergency care and measure capacity and quality of emergency care by measuring proportions of ED visits with 1 of 4 outcomes related to boarding. And those are more than 1 hour to be placed in a treatment space. The encounter ends before medical screening exam is finished. If a patient boarded for more than 4 hours, and if the length of stay is over 8 hours. In our response to that, we made sure to say that the 4-hour time frame for admitted patients was a good place to start, but for patients that are over the age of 65, it's been proven that boarding disproportionately adversely affects them, and that the target time for boarding for them should be less than 4 hours. Next slide, please. And then also in the regulatory space, and just that general advocacy space, in November of 2022, ACEP and 34 other organizations, which included medical societies and patient advocacy groups, sent a letter to the White House sounding the alarm on the boarding crisis. We talked specifically about specialty patient populations, including geriatric population, in that letter. The White House did not get back to us, so we held our own summit in September of 2023, which included stakeholders from all of kind of different factors that go into boarding, including leading age was there. We also invited AARP and the National Center for Assisted Living. They were not able to make that summit, but in that summit, we identified the main causes of boarding, which were transparency, regulatory challenges, mental health and psychiatric boarding, misplaced financial incentives, operational modifications, workforce shortages, and social determinants of health that make certain patients more likely to be boarded. So based on that summit and our previous letter and our ask at the Leadership and Advocacy Conference the year before, Secretary Becerra, who's the HHS secretary, actually directed the Agency for Healthcare Research and Quality, HRQ, to hold a summit and a directors roundtable on boarding, and ACEP is very involved in the planning of that. I'm happy to report that AARP and the National Center of Assisted Living are expected to be there. So there's going to be a big representation of geriatric providers there. Next slide, please. So in terms of next steps, that age-friendly hospital measure that I was talking about was not recommended for CMS to incorporate in their payment systems. However, there needed to be a 75% recommendation in order for the process to fully tell them that they were recommending it. And there was a 73.68% approval rate. So although that's really frustrating, we are anticipating that the age-friendly hospital measure will be incorporated in the IPPS. And I have heard that that is set to come out either tomorrow or later in the week. So we're really excited about that. ACEP is holding our Leadership and Advocacy Conference at the beginning of next week. I hope to see some of you there. One of our big asks will be onboarding, and we are also going to have a panel with representatives from CMS and AHRQ onboarding, and also a woman from Uprise Health Systems who is doing they do a bed tracking system in Oregon, which we are actually really excited about this because based on the bed tracking system in Oregon, we are actually floating a bill in Congress. We have a lead sponsor of that bill, Representative Joyce from Pennsylvania, who is introducing legislation that will help to establish a bed tracking system. So load management will be easier, capacity management. And we asked specifically for something to be in there about beds specifically for geriatric patients to be included in the bed tracking system. As we know, boarding is a multifaceted problem, and while we usually talk to the Health Committee, Finance Committee, ENC, and Ways and Means, we also have been engaging with the Senate Committee on Aging to flag how this crisis affects older populations that have their own unique set of healthcare needs. So we are also, when we talk to those in those meetings, flagging GEDA and really highlighting EDs that are taking the extra steps to make facilities more responsive to geriatric needs. We have a webpage, acep.org/boarding, where you can submit your stories for the horrible boarding stories that you have. Stories always help for us. We pull from them. They're all anonymous, but we pull from them to kind of talk to some lawmakers. Those kind of stories really make a difference. I think legislators respond really well to those tearjerkers, if you say. And then we have a program where you can have a legislator actually come into the ED and see not only the bad things with boarding, but also like the improvements in geriatric care that you guys are making. So really proud that we offer that. That's my email at the bottom of the page, grossman@acep.org. If you have any other questions or want to know more about what we're doing in terms of the boarding crisis. Thanks, guys.
Thanks, Erin. This is Tony Rosen. Connor, do you want me to just start, or is that okay? All right, great. Well, thanks, Erin, and it's a great reminder that there are resources at the national level that are advocating for emergency departments. I'm Tony Rosen. I'm a ER doc from Cornell, and I apologize for hopping on and hopping off. I'm actually in another meeting at the same time, but really excited to be here. And the work that I'm going to present, or the ideas that I'm going to present, the strategies for prolonged ED boarding for older adults. Again, hopefully this is complementary to what other folks have been talking about. But a lot of this content is courtesy of collaborative work with Dr. Kennedy, who's on, and Dr. Josh Joseph. We worked on a chapter actually for a textbook edited by Dr. Shenvi, who's also on, focusing on boarding of older adults in the emergency department, harms and risk mitigation. And so hopefully some of the ideas that were generated as part of that chapter, certainly none of them are necessarily original, but hopefully they'll be helpful to us as part of the GEDC community. So next slide, Connor. And I apologize, I have several clicks in these, so there'll be a lot of clicks, but Connor, when you're ready. Okay, so key strategies to reduce overall ED boarding. The first thing is, they're upstairs strategies. If you look in the top right corner, a lot of these strategies are not ED-based strategies. If you think about what are the things that are going to reduce boarding overall, it turns out a lot of these things originate or need to originate upstairs. The main ones that we focused on, and if you put this slide up, smoothing elective admissions, including for surgical or other procedures more evenly throughout the week and on weekends. It turns out a lot of these are on Monday and Tuesday, and that works for them, but it certainly doesn't necessarily work for us. Reducing delays to discharge from inpatient services to make beds available earlier. This includes early morning discharges, weekend discharges, and use of discharge lounges, among other things. And again, I see lots of folks nodding. This isn't from a hospital executive perspective. These are the critical interventions that can impact us. Next. Enacting surge protocols. So when a critical threshold capacity is reached, there needs to be a plan in place. And as early as possible, that plan needs to be enacted. That plan may be enhanced by electronic dashboards and predictive analytics. And frankly, obviously a very important one, next click, is moving boarding patients from the ED to inpatient hallways. Next click. This is in some ways a third rail for many hospitals. If you don't know third rail, I'm an ER person, I'm a New York person, and the third rail is right on the edge of the tracks, and you better not step on the third rail. It's a very dangerous place to be. And a lot of our inpatient colleagues feel pretty strongly negatively about boarding patients in inpatient hallways. However, there is good evidence to suggest that it is safe, that patients prefer it, and that it dramatically impacts boarding. And so again, that's an upstairs solution. It requires buy-in from the leadership, and it requires buy-in from our inpatient colleagues, but it's an important part of the process, particularly in a surge protocol. It shouldn't just be the ED. Next slide. Here's a sort of a classic. So again, we're now talking about boarding. That previous slide, a lot of that is based on many different articles, but one is an article that Dr. Meldon asked would be included here, and that's an article in New England Journal of Medicine Catalyst by many emergency physician leaders that I highly recommend to folks that are interested in this topic. But again, we're talking about older adults, and so this cartoon that I've added is kind of a nice reminder that what seems to us like just a regular Tuesday afternoon in the ER can be pretty confusing and pretty disorienting for our older adult patients. And so how do we minimize the harm associated with boarding? You heard already that older adults are at particularly high risk for harm, that boarding is actually dangerous for patients. And so what are the two things we can do? We can prioritize older adults for transfer to an inpatient bed. Can we make sure that we get them out of the ER more quickly? And then the second thing that we can do is we can optimize their care while they're boarding in the ED. And I'll pause to talk first a little bit about the first, which is to say, even though I feel like we often say to our patients, you know, we're doing our best here. It's not a restaurant. We try to see people, based on level of concern about their severity of illness. But ironically, we often assign beds on like a first come, first serve basis. That doesn't make any sense. And so at the end of the day, a more sophisticated, a more rational approach to inpatient bed assignment might be really helpful. In addition, again, I'm not going to talk too much about this in this presentation, but we all know that in many hospitals, we block beds for surgical admissions, or we block beds for elective surgical procedures. And that just really doesn't comport with the minimization of harm strategies that we think are important. But I'm also realistic, as we all should be. And we have to also recognize that no matter what we do, older adults are going to be boarding in our emergency department, some for a long period of time. And we have to think about how we can optimize the care that they receive while they're boarding. And so I'm going to talk a little bit more about that now. Next slide, please, or next click, please. Okay. And this comes, I want to credit Maura Kennedy, who I think is has thought about a lot of this stuff very deeply, but we all worked on this together. But Maura really came to the lead in sort of thinking about how we optimize care. There are three ways that we optimize care for older adults in the emergency department. Care progression, next one. Normalization of function, next one, environment. And I'm going to talk about each one of these briefly because they're all important. Care progression. Look, hospitals have created all kinds of different things. Is there a team that focuses on boarded patients? Is there a transitional care unit? Is there a unit outside the ED that the ED manages for patients that don't yet have inpatient beds? All of these strategies are noble. And all of these strategies, I would argue, deserve the same kind of prioritization approach that I argued for on the previous slide. We should be thinking about the patients that are most likely to be harmed by boarding and prioritize those patients for these care progression strategies. But care progression doesn't just include the strategies that I just discussed. It also includes, what about a hospital bed? What about ordering that MRCP or ordering that consultation from physical therapy or occupational therapy or that echocardiogram that's going to shorten the hospitalization on the other end. And so things that we can think of to progress the care of older adults are important. And I'm going to add something else that I think is important, sort of a pet thing from my perspective, as I work in an academic emergency department. In an academic emergency department, sometimes we have patients that are boarding that are in what you might refer to as the bed requested stage. We've decided we're admitting them, but medicine hasn't assigned them a team yet. And this can also be a status that a patient can be in for multiple hours. And that's about the most dangerous environment, is when a patient doesn't have a team. And so another thing that we can do from the perspective of care progression is think rationally about who's going to do poorly without a team. We're all doing our best, but in the emergency department, we're focusing on new patients who just arrived. We're not sure if they're critically ill. We need to see them. And so the things like, it's been 8 hours, is someone going to redose the Zosin? Has someone put their Parkinson's medications on? We're going to do our best for that. But if this patient has an inpatient team, that's going to make a big difference, even if they're still boarding in the emergency department. And so I think that's something that we need to focus on. Normalization of function. Turns out that we can do a lot about this. And I'll talk about this a little bit more on the next slide. But think about the things that we do to prevent delirium. Make sure that people are mobilized. Make sure that people have access to their assistive devices. Make sure that we are reorienting people. And then again, in the environment, are there things in the environment that we can do that are helping to prevent delirium? We like to say, I know I've heard Dr. Kennedy and others say that if you don't arrive in the ED delirious, we've got a lot of interventions that can make you delirious while you're in the emergency department. And so we need to be thinking about those things, and we need to be combating those things. We need to be thinking about, what are the strategies in the environment that can promote sleep? Can we put them in a room? Can we close the door? Can we turn out the light? Can we move them into a corner away from the chaos? Are there things that we can do? Can we make sure there's a large clock? Can we do rounds to reorient folks? What are the strategies that we can do while our patients are boarding? Remember, one of the things that I want to encourage us to do is, in emergency medicine, I remember learning when I was a resident, A, B, C, D. First you manage the ABCs, and then the D is for dispo. And once you have a dispo, you move on. One of the things to keep in mind is that these are patients that you have a dispo, but they're still under our care, and they're still at risk for harm. And so there are things that you can do. Next slide, please, Connor. Okay, here's a framework that I thought I would add, because Maura and myself and others worked on this just a few days ago. The 4 M's. I'm sure you've heard about this before during this couple of hours, and I'm sure you'll hear about it again later in the presentation. But from my perspective, the 4 M's are really important throughout the life cycle of care that older adults receive in the ER and in other clinical settings. But they are very helpful in organizing how we might approach older adults who board. The first thing I'll say is that I like to emphasize, next click please, that the way to think about these 4 M's is to start with what matters. That's the M that drives the other M's. And so imagine this. Imagine this. The first thing that you do is you say, hey, unfortunately, there's no room at the inn. It's going to be a while. Unfortunately, you're going to board in the emergency department for a while. What is important to make you comfortable during these next several hours? What can we do? Well, there's a lot of things we can't do, but what are the things that we can do to make you more comfortable? Also, consider whether alternatives to the hospital are appropriate. Hey, if you and I together are not sure that you staying in the emergency department for the next 10 hours is going to help your pneumonia, do we think that we might want to trial a urgent care visit or virtual urgent care in 24 hours? Are there other options rather than admission? Because we want to think about what matters to you. And what matters to you drives the other 3 M's. I'll go briefly over the other 3 M's. Medication, reconciliation by a pharmacist. redosing acute medication, and other critical home medications, such as Parkinson's medications or other neurologic medications, as well as pain regimen. And by the way, we love PRN medications in the emergency department. That's an area of particular expertise, is PRN medications. Not for pain in older adults that are boarding in the ER, please. How about standing medications when possible? Physical therapy and occupational therapy, in my opinion, these folks should be in the ER all the time, but I'm not a hospital executive. I'm an ER doctor. But what you can do is you can order the consultation right away. Let the occupational and physical therapist know that you have a patient in the ER who you recognize needs their evaluation. Volunteers, we are lucky to have wonderful volunteers in many of our emergency departments, and helping them, asking them to help our patients safely mobilize, as long as they're trained, safely mobilize can make a big difference. I'm a big believer, as I know many others of us are, that early mobilization can be a game changer. Nursing, ensuring patients move regularly, particularly our patients that may need assistance in movement, and a bedside commode. These are the kind of interventions we do upstairs. Why not doing them downstairs as well? What about the mind? Making sure the patient has access to glasses, hearing aids, hearing amplifiers, arranging for family and caregivers to remain at the bedside, putting a chair. This is Carolyn Hullock used to say, you got to put 2 chairs by the bedside, encourage family to stay there to reorient the patient. Volunteers to socially and cognitively engage patients, and frequent reorientation by staff. Next slide. What I also wanted to emphasize is this. It turns out that by having a GED, you're already reducing boarding and you're already reducing its impact. So think about the things that you're already doing as a GED, and remind your colleagues and your hospital executives and yourselves how important the GED itself is to this practice. 1, it minimizes unnecessary admissions. The GED process is always thinking, what's the right thing for the patient? What matters most for the patient? It decreases length of stay for patients that are ultimately going to be discharged. And again, I don't want to get political, but I really like this. This is not my idea, but the idea of a border patrol. Is there an ED-based team that can be ensuring that there's communication with patients, that sets expectations, that also focuses on ensuring that we're doing everything, that our list of optimization interventions is actually being implemented. Next slide. And I really like this article. This is from a team led by Fernanda Bellolio at the Mayo Clinic. And one of the things that people wanted me to point out, and I like pointing out, is the Geri ED Comfort Cart can be a big intervention for boarders. Here's a picture of the Mayo Clinic's cart, and it's useful. They actually published this in the American Journal, along with a list of comfort items. Look at this. These are things that you can request that can improve your comfort. And so you can imagine a volunteer even going through this list with a patient. Think how empowering that might be. And also look at this cart and all the things in this cart that can reduce delirium and frankly reduce the impact of boarding on older adults. And so I think that the Geri ED cart that already exists, really important. I can see there's some great things in the chat that I'd love to respond to, but hopefully folks are going and talking amongst themselves. Next slide. Okay. I also want to acknowledge many of us on this call either do serve currently or have served, or perhaps are interested in serving, and I'm sure we'd love to have you contribute to the Geriatric ED Accreditation Board of Governors and process. And so one of the things that the accreditation process wanted to do is recognizing that boarding really clearly, there is evidence for harm. But in addition to evidence for harm, there are potential solutions, the solutions that I've just been enumerating. And so in recognition of the adverse effects of prolonged boarding, including delirium and functional declines, a lot of things, but those I want to focus on, delirium and functional decline, the Geriatric ED Accreditation Program proposes 2 separate things. Connor, you can click when you're ready. Okay, I wanted to emphasize there are 2 things, the carrot and the stick, or if you like, the stick and the carrot. Let's focus first on the stick. The stick is that we're requiring level 1 and level 2 geriatric EDs to track ED boarding times. Would we like to have thresholds? We would. We recognize that we're not there yet as a field, frankly, as a healthcare system, but we think that just tracking it is an important first step. And if you want to be a level 1 or level 2 geriatric ED, you must track boarding times and a couple things. One, you must track boarding times, but also you can see you must compare older adults to everybody else. It's not just enough to track. You have to not necessarily, we'd like you to prioritize, but at the very least, you need to demonstrate that you can track both. You can track the median boarding time for older adults and the median for everybody else. You can track the number of older adults boarding for more than 4 hours and everybody else. And that you can have both of these numbers, and that you can, again, one of the things we want to do in the geriatric ED accreditation process is empower the ED to have these conversations with the C-level of the hospital. And by demonstrating these numbers, I think that that's an important first step. And that's the stick. But we also want the carrot. We also recognize, and this is also Dr. Maura Kennedy has focused on care processes, as you know. You need a lot of care processes to be a level 2, and you need even more care processes to be a level 1. But you can choose between these care processes. And so we've added optional care processes that fit in with exactly what we've been describing. The first one is minimizing the boarding. So we want a care process to minimize boarding, specifically for older adults, perhaps including prioritizing them for not only care progression, but for leaving the emergency department, given the known additional risk of harm. Not only are we necessarily asking for you to prioritize older adults, but we also like the idea of potentially prioritizing that subgroup of older adults who are at particularly high risk for delirium or harm. Those might be folks, we don't yet have evidence on who exactly those folks are, but we certainly know who's at highest risk for delirium, and it would be reasonable to focus on those folks, or perhaps on folks that have specific functional issues or at very advanced age or themselves have dementing illness. So from our perspective, we want to focus on minimizing boarding, but we also want to focus on optimizing experiences. That's a separate care process, is a care process where you design a process within your emergency department that optimizes the experience while boarding, either for all older adults, or if you have fewer resources or want to focus those resources on that set of older adults, that subgroup that you think are at particularly high risk for harm. So again, I apologize. I hope that's helpful. I'll be on for another second or so, and then I have to go back to my meeting. But thanks, Dr. Meldon, for leading us and everybody, and thanks for the invitation. I think this is a super important topic. I know many of us, when asked, say this is the single thing we'd like to fix in our emergency department. It is prolonged boarding. And so I'm certainly excited that it's an area where many of us are interested in focusing and want to make a difference. So thanks very much.
Really, thank you. All right, we had some good chats, and we can open this up. We have 10 minutes and lots of good discussions. So once again, either in the chat or probably the best way.
Maura Kennedy has a question, and then I have a few that I've recorded throughout the session, Steve, that I can review. But Maura, why don't you go ahead?
So I have a question that comes out of what I've heard in a number of these presentations, Tony's presentation, my presentation, Lynne's presentation, which has to do with equity. So certainly we see that older adults are less equitably assigned inpatient beds for a myriad of reasons. Lynne raised the concern of differential pickup of patients by the nursing teams. But I also am concerned about the potential unintended consequences of some of our recommendations. And, you know, if we create certain processes to improve the care for some of our older adults, will it be equitably distributed? And so I was just wondering how currently some of us are monitoring boarding and equity of the boarding or disequity, and thoughts on best practices to make sure those care processes or those interventions we implement are equitably distributed.
I'm happy to call on the panelists if that would help. Lynn, do you have a response?
Well, I was just trying to reflect. I mean, we are using very straightforward, simple, if you're greater than 75. And so I'm trying to think of if I have observed those flow nurses going any deeper, or are they're probably going longest time boarding, age greater than 75, and then pulling. But I think it's something that I'll have to look at and observe and see if there's anything more going into that. And then we have yet to work closely, and I hope that work is going to begin soon, to develop the matrix, the algorithm. And I think having that lens is a really important one, as we described, because you rob Peter to pay Paul. There's always going to be, you focus on the seniors and someone else is, getting left behind. So I do think it's a very important lens to have, but I can't say that I have all the answers.
And if
When
we
you do
can-
come back to us.
Okay, I'll work on it.
And
Please.
if we can tack on, as you're answering Maura's question, the other question that was asked early on was, what is your proportion of older adults that are boarders? So if you could give a general census of what is the proportion of boarders that are older adults, and then also speaking to the equitable lab.
Well, we know that that older adults are more likely to be admitted, so they obviously are disproportionate just from that alone, right? That's why we're trying to prioritize them. So they make up essentially, I think it's well over half of I think it's 60% or so of our admissions, right? So I'd have to look at the exact numbers, but we certainly know that they're more likely to be impacted, especially when you think about if they have dementia, do they need a sitter, right? Think of all the things we have to do to set up an inpatient bed and the care for that patient. So certainly that's not uncommon.
I think we lost Tony, so I'll go ahead and move forward with some additional questions, unless Maura, you want to speak to it specifically.
In terms of our older adults, most of our older adults board in our emergency department for prolonged periods of time, unfortunately. We do have a boarder service, and we do have a separate part of our area of our emergency department that was originally our fast track and is now our flex, and has become sort of a boarder area with lights that go down and sort of optimized. And that's where boarder nurses are, and boarder doctors take care of those patients. Unfortunately, not all of our patients are covered by the boarder service. There was a study that showed that in our hospital, patients that get covered by a hospitalist have shorter length of inpatient stay compared to those who are uncovered. The shortest was those who are directly admitted upstairs with a coverage team, but certainly having those teams can reduce inpatient length of stay, which I do think is important. I do worry, though, that there is not equitable sort of assignment to those spaces, but I don't know, because I don't know that we're looking at that.
The next question was from Dr. Mike Logan. There was a question related to understanding a little bit better about the patients that are receiving hospital at home. And he provided some examples. Is it, folks that are stable heart failure that need diuresis, IV antibiotics. Before I turn it over to Dr. Meldon, because I think it was specifically for you, I will just say, as a former visiting nurse, I often would get discharged ED patients, and I was not hospital to home, but that were stable heart failure needing diuresis, IV antibiotics. That was a very common practice of ours. And through many different home care specific programs that we had, where we would tailor the amount of visits depending on the frailty and vulnerability of the patient. We would do phone calls, telemonitoring, and things like that. We had incredible success on reducing the readmission to the ED. So I think with some of those tailored approaches, specifically to your frequent flyers related to chronic diseases, heart failure, COPD, there is an absolute opportunity there to reduce the likelihood that they return. Dr. Meldon, do you want to speak to that?
No, I think that's right on. I think there's a couple of things to think about, right? One, obviously, is the medical needs, right? Obviously, we don't do critical care at home. Maybe not yet, right? Who knows what's next? We're already in the parking lot taking care of patients. I think the next thing is really do they have the social support structure? What other things do they need, right? Because it's not just a question of, oh, you need antibiotics Q12 hours parenterally, you know, or a dose of Lasix and we reweight and then another dose of Lasix. So I think we look at those kind of really important components to say, is this the right fit? And then patients have to buy in. And that's been kind of one of our learning points is like, who's selling the program? Patients still think it's safer to be in the hospital. I don't want to tell them it's not, but it's not, right? I'm afraid if I tell them that, they won't want to come in the hospital when they need to, right? So how do you basically say, we're going to give you hospital care in a more comfortable setting at home? And here's how we're going to do it. We're going to have nurses come out, we use telemedicine, right? Community paramedicine, whatever components you can build into your program.
Connor, I don't know if you want me to turn it back over to you. We do have a few more questions. I know that Christy Foster, do you want to jump on real quick? I think maybe we can have a chance for one more question.
It wasn't a question. I was just going to share that I worked with our inpatient leadership team to come up with an algorithm so that patients that are 70 and older are going to be at the priority admission. And then those that screen positive or for risk for delirium are the highest priority. So as we were talking about algorithms, I just wanted to share that that's been, I feel, successful because it's not debatable amongst nursing teams. It's this person's screened positive, this person's greater than 70. This is going to be the next admission. So I was just sharing that that's something that we've come up with and I think has been helping.
Yeah, the more objective, the better.
Okay, last and final question. This was a question for Dr. Meldon during your section, but I'm sure others could answer. It was specifically around, can you speak to how you're predefining high-risk criteria and specifically about how this was built into your EMR system? But perhaps others could to discuss as well, how are they defining high risk?
Thank you. Because this also goes back to Maura's point, where this may, if you design it right, could actually promote equity, right? Because it's fairly objective data. So what we did was really with our team of geriatricians, pharmacists, et cetera, to say what do we know that is high risk? And what can the EMR grab for it? It has to be discrete data at this point. Come talk to me in a couple of years with AI, and I'm sure we'll be much more advanced. But we use age plus additional risk factors. And if you're 65 to 79, did you present or do you have a history of falls, cognitive impairment, polypharmacy, which we define as greater than 10 meds. When I started this field, it was greater than 5. Nobody's on 5 meds, right? We also use frequent ED visits. If you are coming back all the time, 5 visits in a year. And then also the delirium screen goes into that. So by freeing up the EMR to kind of screen the patient and not have to do ISAR or TRIST, we now do our delirium screening way up front in triage. So that goes into this. That is what drives then a high-risk banner that goes to the providers. And that also then goes to bed management. So to your point, Christy, that's delirium is one of those if they already have it. And if they don't, those people are at risk, right? 80-year-old, fall history, polypharmacy, and cognitive impairment. So that's how we do that. I did put a link in to the paper and Jeremiah open. All right. Well, we are at time. I'd like to thank all who joined us. I really want to thank our presenters, Maura and Lynne, Erin, and Tony. I thought this was, once again, great job, Connor, with the GEDC, and thanks to our West Health partners. Final thoughts from the team?
I would just remind everyone, well, thank you to all of our panelists and everybody who attended today. And I would remind everybody that our next Healthcare Systems Roundtable is going to be a thought leadership event on health system strategies for value-based care and age-friendly health. And that's happening on August 13th. And you'll receive more info on that in the coming weeks.
All right. Thank you, everyone. I think we can be adjourned.